Okay, chapter 15, injuries to the muscles and to the bones. Now we are, as EMRs, going to be the first ones on scene, and so we're to see a lot of these injuries to the human creature, especially as a result of car crashes, um, uh, residential problems like trees falling on them or ducts giving way or whatever. Fractures, dislocations, sprains and strains. Basically, if you remember DCAT BTLS, right? Deformities, contusions, abrasions, burns, punctures, or excuse me, punctures, penetrations, burns, tenderness, lacerations, and swelling. That does cover quite a bit of these things, and so we're going to cover them, uh, and then we're going to learn how to treat them in class. But to do this, you have to understand the basic anatomy and functioning physiology of a human creature to be able to do these things and do them properly. You also need to know the signs and symptoms of um, the smaller things that you may not understand. You may not necessarily think, "Oh, that's a big deal," until you see these like battle signs or things like this. You need to be able to provide initial care, stabilizing the patient, but we have to make sure the ABCs are done first. Speaking of ABCs, we start with the scene size up. We always start. See, we do the things the same way every time. That way, when we get to the new thing that the patient is exhibiting, we're able to take care of that new thing, right? So we do the scene size up. Is my scene safe? All that kind of thing. Then I look over for ABCs. Then I start my sample history, right? And we move on it from there. We have to be able to do what we normally do. We can't stop and think about it. We have to start with our BSIs to make sure that we're safe because with brokenness, there's a possibility that they're bleeding as well, right? Get that ABCs done, start into our secondary assessment, and while we're doing that, get the vital signs and the sample history. And make sure that you keep looking for changes in the patient. Are they acting funnier? Are they not doing things correctly? Or are things swelling on them, right? Now, our skeletal system, our body consists of 206 bones. Now, for us in the EMR, we just need to know the relative terms. We don't need to know the names of every single one of them. But the function of the skeletal system is to provide the framework for our body, right? That's what it does. It provides the framework and protects our organs. It doesn't really move, but because we have hinge joints and ball and socket joints connected to our muscles, then we can go ahead and it assists in moving. It doesn't move itself, right? But the bones, the bigger bones, they help with the production of red blood cells. We've got 7 basic areas here divided into these sections. You have the head, which is the cranium. You'll hear that called that. A lot of people use the word skull. We have the spinal column, and while that is pointing to the neck, it goes all the way down. Those circle vertebrae go all the way down. We all know that from our basic anatomy from high school, or from grade school actually. You have the shoulder girdles on either side. That's a specific um, uh, hinge point where there's multiple bones converging. Then you've got the rib cage. There's 12 sets of ribs, right? And we got 7 true ribs, which means they connect from the vertebrae all the way to the sternum, and you've got 3 false ribs, which means they connect from the vertebrae to another rib before they connect to the sternum. And then there's 2 floating ribs, 2 sets of floating ribs, which means they don't connect to the sternum at all. They're just out there back there. Those are the ones that are very painful because there's really no way to stabilize them. Pelvis is a huge area that's disrupted. We also have the upper extremities, the arms, and then finally you have the lower extremities, which are the legs, right? And so those are the areas that we need to be thinking about when we're talking about the different types of bones that we may have to take care of. Now, as we begin to talk about deformities and damage to these areas, um, there are actually many bones in the cranium, in the skull, including the most movable one, which is the lower jawbone. That's how you talk, right? The jawbone goes up and down, and your tongue moves on the inside. That is the mandible. A lot of people call it the jawbone. And that consists of of your cranium, of your skull. But if you wanted to drill down to it, you have many fused bones in there. You have the frontal and the parietals and the occipital and the zygomatic and the orbital and the nasal, right, and the maxilla. And those are just the main ones. There's a lot of smaller ones in there as well. Temporals, don't forget the temporals. And these bones in a specific region are fused. So if you were to look at the skull, you would see little suture marks there where as you grew from a child, this is where the bones grew, right? Our spine, though, is a very complex system of support that houses our nervous system, our central nervous system, right? And it has 5 main sections. So right here you see the cervical spine being right there at the top. So when we say C-spine, that's what we're talking about. Now look at the shape of these bones. You'll see that they're different in different places based on what they're supposed to do, right? So you have 7 cervical spine bones, C-spine. Now the C1 is called the atlas, and C2 is called the axis. That might be nice to remember. If you get broken between 1 and 2, you're pretty much toast. There's no way to survive that. You need C3, 4, and 5 to stay alive. The higher the break, the less likely that the body will survive, because that's where a lot of your autonomic systems pass through. The thoracic vertebra, there are 12 of them. Coincidentally, or not coincidentally, depending on how you want to look at it, there are 12 sets of ribs. That's where your ribs attach to, is those vertebrae. Okay? Then you have 5 lumbar. Those are your big meat and potato ones. That's where a lot of the pressure of your body sits, and so that's where you'll see back problems with people. Now notice the sacrum. The sacrum is a fused bone. There are 5 fused sacral bones, and there are 4 fused coccyx bones. And the coccyx bone is actually called the tailbone, and that's where, if you have a tailbone fracture, that's where you sit on that one, right? Okay, and then we also have the upper, each shoulder. It supports the arm. It has the clavicle in it. It has the scapula in it, the collarbone, the shoulder blade, and then each of the upper extremities have 3 main bones. You have the one big one in the upper arm, that's the humerus, and the 2 smaller bones in the lower arm, which is the radius and the ulna. Remember, when you're standing anatomically speaking, that the radial bone is connected to the thumb, and that is more lateral to the body, and the ulna is more medial. In the thoracic area, you've got those 12 bones, and I've already talked to you about the true, the false, and the floating. True, you've got 7. False, you've got 3. Floating, you have 2 sets, right? And remember, true connects from the vertebra to the sternum. False connects from the vertebra to another rib before it connects in, and then the floating ribs. Don't forget the xiphoid process there on the sternum. If we are doing CPR and we go too low, we could snap that off, and that could perforate the diaphragm or lacerate a liver or something along those lines, which is not a fun thing. Now, when we talk about the pelvis is the connecting point between the upper part of the body and the lower part of the body. It houses all the genitalia, whether you're male or female, relatively speaking. You have your bladder in there. And if we fracture that, there's a lot of blood loss that can occur right there. And so when we're looking for destabilizations in that area, we're looking for, is there a problem with the pelvis? If they're bleeding from the rectum, if they're bleeding from the penis or the vagina, this is a good possibility that we fractured this area. The lower extremity consists of 3 bones, just like the upper does. The largest bone in the body is called the femur. It's the longest and strongest of the bones in the body. So if that bone is broken, the mechanism is pretty high. Okay, and then the lower leg is the tibia, which is the larger of the 2 lower bones, and the fibula, which is the smaller. Very common to break the fibula, and you wear the boot and you get it all. But if you break the tibia, you've probably broken the fibula as well. There's also the patella, which is the kneecap, we don't have an elbow cap, but so we have the patella down there as well, which is the kneecap. Now, our muscles on the other side of it, so we've talked about the structure of the bones. Now we're going to talk about the muscles. We briefly touched on that in our soft tissue injuries, but these are the ones that cause the body to move along, right? Our muscles provide the movement, right? And muscles are held together by uh, ligaments. Excuse me. Bones are held together by ligaments, and muscles to the bone are held together by tendons. Okay, and so we could pull a tendon, and that could uh, think of a chicken leg. If you're going to have a chicken leg and that grizzly little piece at the end, that would be what is called a tendon, right? That little hard part that you don't. That's the connection between the muscle and the bone. Okay. And anytime that there's a muscle connecting to the bone, there's pretty much that's where you're going to have a movement point. You have three different types of muscles. You have, and we talked about this in the anatomy. You've got the cardiac muscle, which is found only in the heart. There's no other place that you'll find muscular cardiac muscle. It is a very specific type of muscle. It's found only in the heart, and it is excitable by itself, meaning its automaticity, which means it can start its own heartbeat independent of anybody else telling it to go. Then you have skeletal muscle. Skeletal muscle is your biceps and your triceps, anything that makes you move, anything I have control of, that is a skeletal muscle. And then anything that I can't control, like my intestines, right? My stomach, again, digest faster. Can't control my liver, right? That is all created from smooth muscle. So those are the three types of muscles. Now, when we get into an accident, when we have a problem, when we have a trauma, there is a mechanism of injury. Okay? And there are three things that cause this mechanism of injury. I have a direct force, which means I get something direct impact, right? And you see in this picture where the knee goes directly into the dashboard, that's direct force. Now, the indirect force here is the reaction from another part of your body taking direct force. And you see your hip being displaced, the femoral head popping out of the socket. And then, of course, you have the twisting force. Anytime that your body twists opposite of the way the rest of your body is going, we have a mechanism of twisting. So we might start gathering some of this information as the dispatch comes out, right? You are on a rollover PI or a head-on PI, or there's a tree falling on somebody, or blah blah blah, and we have to listen to that information from the dispatcher, and then begin formulating what we're going to do for this patient before we even get there. Okay, doesn't mean that's the way it's going to be. It just means that's the way we have to start. Okay, and as we come on there, we have to start using our senses, our sight and our touch to give us additional information. Do I see that it's dislocated? Do I see that it's swelling? Do I see bruising? And I'm going to try to stabilize the patient as best as humanly possible to prevent further injury and to reduce pain. Now let's talk about fractures. A fracture is where a bone is flat out broken. When you touch a fracture on somebody, you will feel a bone-on-bone grating. It'll feel like gravel under the skin, and it'll elicit a lot of pain. It's crunchy, crunchy, and you're like, ooh, that's broken. So we're going to stabilize that. Now that could be any one of, 3 or 4 or 5 or 6 or 10 different kinds of breaks. They've got all kinds of names for them. But the point of it is there's broken bone there. Okay. Most of the time, there's some sort of a force that creates it. You don't just, ooh, I broke a bone and fall over. Although I have had people that have just fallen in the grass and they've broken their pelvis. There's a whole different set of problems. They had osteoporosis and all kinds of other things that were going wrong in their world as well. If the fracture is closed, meaning I can see the bone pressing against the skin, but it hasn't broken the skin yet, that's a closed fracture. But if the bone is sticking out, it's an open fracture. Now, we may have to deal with some bleeding as well. So which one do you deal with first? The bleeding or the fracture? Well, which one's going to kill them? The bleeding's going to kill them. So I got to stop the bleeding, right? A lot of people go, I got to fix that fracture. Fixing the fracture may, in fact, help slow the bleeding down, but it's not going to stop it. I have to stop the bleeding, and maybe I'm doing two things at the same time. but my priority here is the bleeding that I have to stop. Okay, and it could also be internal bleeding that we can kind of mitigate, like in the case of a femur. If I break the femur, yes, I'll be bleeding in that area, and I stand the chance of bleeding out a lot in there. Now, a dislocation is different because it's just ripping the ligaments, maybe even disrupting the tendons in those areas. It doesn't necessarily mean that there's anything broken. It's just pulled out of joint. It's like taffy where I've pulled it all apart. Um, it's definitely going to cause pain of extraordinary measures, and we don't want to try to put it back where it belongs because it could damage nerves and blood vessels and so forth. So in the event of a dislocation, it doesn't look like it's broken, no jagged this or that. I'm just going to splint it position found and make sure that the transporting EMS understands what's going on there. Again, sprains and strains, kind of like a dislocation, but instead of bones being dislocated, they've just pulled and come back into place. Now, this is going to be extremely painful. Probably will have some bleeding and bruising with it, but non-life threatening. And it probably doesn't need surgery, but we're gonna splint it in position found anyway. Maybe put some ice packs on it to kind of take the swelling down and to alleviate some of the pain. Okay. Now, obviously, what we're looking for is pain at the injury site. If they say they have a broken arm and they're like moving it all around and there's just a little bump there, that's probably not broken, right? Um, but if they can't touch it, it hurts right here. Well, and there's some swelling there, there's some discoloration there. Probably going to be calling that more along the lines of a break. Definitely, if you see a deformity or angulation, if there's an extra elbow in the arm, there's only supposed to be one. If there's two, that's a problem, right? Tenderness at the site could indicate a break, but if that's the only thing you're seeing, I would be cautious to call that a break. And quite honestly, we're going to be using a differential field diagnosis, and that means that that's our best guess. It doesn't mean that's what it is because we don't have x-ray vision to see what the bones and the muscles and things are doing. So what are we going to do? We're going to assume that on our way to a call where there's trauma, that there's going to be open wounds. And I'm going to be prepared that way. Definitely going to be wearing gloves. Probably going to want some eyewear on. I have glasses right now anyway. So I got some from frontal. Maybe you want to have a shield on your face or whatever. If you're going to be involved in helping people out of a motor vehicle crash, your exam gloves are not extrication gloves. And so you are going to have to really be mindful of wearing the heavy rescue gloves so that you are being safe in there, which may mean that you will have to have exam gloves underneath it so that you can be protected because the extrication gloves are not bloodborne pathogen gloves, okay? Active bleeding may splatter, so we got to make sure that our eyes, nose, and mouth are in fact protected. Now, as I'm going through my assessment, I start with my ABCs. That always comes first, right? And after the ABCs are stabilized, I'm going to do a head to toe to make sure that there's nothing that's broken, that'll be moving around, that's going to cause more damage, because I don't want to do that. Remember, ABCs have to come first. Broken bones never killed anybody, unless, of course, they were bleeding, which is the ABC problem, right? Now, I will tell you that broken bones can look very horrific. People are going to want to take care of those first because they look so terrible. But the problem is, if you do that and you miss an ABC problem, they'll be a very stabilized dead person. So make sure that we're taking care of the ABCs first. As you have finished your ABCs, your primary assessment, you get onto your history taking and so forth. Now you can move into inspecting the injured limb, compared to the other limb. Is there any open wounds? I'm going to fix it because an open wound doesn't necessarily mean they're bleeding, but I do want to take care of that. Is there any deformity, swelling, bruising, that DCAT BTLS that we've already talked about, right? We're going to palpate. Now, this is part of the assessment, right? We're palpating circumferentially. Notice that this EMR is feeling on both sides all the way around to make sure that there's stability there. Do I feel any broken bones? Do I feel that their muscles are all kitty jankus? Tenderness is the best indicator for problems underneath, right? We need to squeeze in a firm and systematic manner. We're starting at the top and we're going all the way down. Whatever way you do it the same way every time. Let me say that again. However you do a patient assessment, do it the same way every time. As you're feeling down, one arm, one limb at a time. Don't do both at the same time, because if they say, ow, was it the right or the left? You do one limb. Hey, tell me if you feel anything. Is there anything that's awkward here? Anything hurt in this specific place? If they show no signs, move on to the next limb, right? CSM. I'm going to check for circulation, sensation, and movement in the distal portions of all extremities. I'm gonna squeeze their fingers or toes. Can you feel that? Can you wiggle? Right? And can I feel a pulse in that limb? That is how we do for CSM. CSM, circulation, sensation, and movement. Now, if I have an open wound, if I have any kind of wound, actually, I want to treat it, relatively speaking, the same way. Again, just like a patient assessment, we're going to do the same thing the same way so that we don't miss things. It's a very systematic way of doing things, right? So I'm going to cover all open wounds with dry sterile dressing. If it is bleeding, I'm going to put firm but gentle pressure to control the bleeding. I'm going to use as much pressure as needed to stop the bleeding, right? Even over a broken bone. If it's still bleeding, I'm going to put a tourniquet on it, and then I'll put a splint on it. But again, I'm taking care of the ABCs first. If it's a closed wound or any of the other things, even after I get it dressed and bandaged, I'm going to maybe put a cold pack there to help keep swelling down and to help numb it out, control some pain. The reason why we do splint people, rather than just leaving them the way we find them, is it helps to prevent broken bone ends from damaging underlying tissues further. It keeps the dislocated joints from hurting further, right? And it does cut down on bleeding. If everything's back the way it should go, the body goes, okay, we can repair this because everything is the way it should be, right? And then we don't want open or closed fractures to become open fractures, especially moving around. However, when we're in a trauma situation and the person is obviously mashed up a little bit, we're going to have to do what's called a trauma strip. We want to make them trauma naked. I'm going to cut all of their clothes off. I can leave the underwear for the most part, but I've got to, unless it's in my way of me taking care of them, right? If I've got some bleeding in any of those places where are the no-no regions, if you will, I've seen breasts being ripped off where we've had to stop the bleeding there, or they've been severely gashed. You're going to have to remove the bra in that instance. Testicles ruptured from a compression injuries. Going to have to, put light dressings down there to kind of keep everything in one place. Other than that, we're going to just kind of keep everything. The underwear can stay on, but the rest of the clothes have to go. Being mindful of where we are in the universe. Am I going to do that for everybody in the world to see, especially if there's a ton of onlookers? No. I'm gonna get them in the back of the ambulance and do it there, or I'm gonna get them someplace else where it's stabilized, right? If I have to absolutely do it there, I'm gonna have a sheet or a blanket available and a couple of extra hands to kind of keep that going there. I have to make sure that I'm noting, do I have pulses and cap refill and sensation and movement before and after I splint, right? So we do CSM checks both before and after we do our movements or do our procedures. If at all possible, don't move the patient until you splint them up, because we don't want to create additional damage. If you have to, pull them along the axis of their body, which keeps them, relatively speaking, in anatomical position. All rigid splints should be padded, and there's padded board splints, and you got cardboard splints, and you got the SAM splints. There's all kinds of stuff there, but we don't want to be moving their limbs around, their injuries around. So splint in position found when at all possible, and if there's any doubt whether it's broken or not, sprained or not, go ahead and splint it. You ain't gonna hurt nothing. Cardboard, the one they're both disposable splints, okay. But the one on the left, the A one, is a padded cardboard splint. Excellent for minor wounds. However, if it gets wet, it's pretty much useless. Right? You see some wire splints at times. The padded board splints that you can get, the rigid splints, basically those are one buys with padding on one side wrapped in plastic. Very disposable, very easy to use and then discard. Yes, there are some soft splints. Most of the time, they're vacuum splints. Uh, don't really see too much of the air splints anymore. However, air splints are good in a select area, but air splints are subject to air pressure. Is it hot or is it cold? So if I put it on in a cold atmosphere and I go into a warm atmosphere, it's going to loosen up. If I put it on in a hot atmosphere, excuse me, reverse that. Now, if I put it in the opposite atmosphere, when I go in, it'll loosen up when it's warmer. So we've got to make sure that those air splints, we're continually reassessing CSM. I love the vacuum splints because we put those on and evacuate all the air from there, and it takes these little bean bags in there, the little beans in the splint, and it locks them into place, and it forms perfectly to the injury, and you don't have to worry about did I splint it in position of how or not. Yeah, I did because it's still in that exact same place. You see here, this is a example of an air splint. And so what you do is you stabilize, put the arm in there, and it's very flexible. Then you blow it up. You see the little tube there on a one-way valve. And once you're doing that, it'll secure that arm in place. And you're going to be able to see through it to see if there's any discoloration or what have you. But again, those are very open to problems, especially if there's a nick or a cut. Now it's useless. Same way with a vacuum splint. Now, the one thing that we haven't talked about, and it's hard to watch it done here, but a traction splint is for um, the femur. Now, your slide says 2 trained EMTs. The state of Michigan allows EMRs to do this. So I want you to know that this is typically an EMT skill outside of this state. Okay. However, in the state of Michigan, you are allowed to do this. And we're going to practice this in class. Okay. So make sure that you are ready to do this when you come to class at some point. This is going to be stabilizing of the femur. We're going to pull traction. We're going to put the traction splint on and keep that big bone from slicing into itself. We also use things like slinging the swath. Now, I don't put the sling on this way. I put the sling on the opposite way so that the front of it goes along the opposite shoulder so I have more control of that. It's potato. You can do it either way. Nobody's going to throw you in sling jail for that. The swath, as you see on the right side, holds the sling to the body so that it doesn't sway back and forth. I would use the same thing for a shoulder dislocation and even an elbow injury. But maybe, depending on what's going on, I'll put a pillow or a rolled blanket to pad the voids so it doesn't bounce around. But we don't want to move this around at all if humanly possible. Right? There's an example of, I put a pillow around it and I've tied it into place with cravats, otherwise known as triangle bandages. We can do that, but whatever you do, however you splint, you need to make sure you still have access to CSM. I need to check, do I have circulation? Do I have sensation distally? And can they wiggle their fingers? They may not want to, but can they? Right? We won't make them do that a lot. This might be some sort of a modified sling here to help them hold into place. And I'd probably transport this patient sitting straight up. Forearm injuries, pretty straightforward. we're going to use a rigid splint and hold in place. Again, we're going to cover this in class. And you can look at your skill drills. The other slides show to kind of show you these things, but we're going to cover all of this in depth in class. Fingers, wrists. I'm just going to kind of hold it in place, right? I can do buddy tapes with the fingers if I have to, but for the most part, I'm just going to stabilize the position found. However, if I have an amputated part, meaning I have a finger that's missing, oh, is this your finger? I'm going to take that and put it in a plastic baggie, like a Ziploc bag, and I'm going to make sure it goes with them to the hospital. If at all possible, I'm going to put that on like a cold pack, um, so that it remains cooler. It'll slow it down and kind of put it hypothermic so that the tissue degradation doesn't occur as quickly. Any wound, I'm going to cover with dry sterile dressing, put it in position of function, and then we're going to wrap it into place. Again, we'll do a lot of this in class so you can see what this looks like. With a pelvic fracture, we could lose quite a bit of blood in there. Notice here this EMR is pushing down and in to see if there's any pain there. If there is, I'm going to go ahead and I'm going to bind up that pelvis. Now I might bind that with a sheet, or I might use, there's actually a device out there that's a Velcro and then a pull tab. Nifty little device. It's quite expensive, but it definitely keeps the pelvis stable. But typically speaking, when we're talking about pelvic injuries, hip injuries, these are the older folks. I found and broken my hip, that type of thing. Probably going to have, it's going to seem like a high energy, but again, I've seen people break their hips by just standing level fall. That's osteoporosis that goes on there. We have to immobilize the way we find it to keep from causing additional injury. We don't want to be moving them around. So that hip binding is very needed. With a hip fracture, if the patient is laying on their back, their toes will be rotated out, right? The foot will be rotated out. Oh, by the way, that's one reason that you would still do a backboard. You want to have splint of the whole body. Now, with the femur, with the thigh is what they're calling it, that you would see where the leg is rotated in and shortened, right? So with a pelvic fracture, they're not going to be shortened; it's just going to be rotated out. With a femur fracture, your muscles when that bone breaks, contract and it pulls the foot inward and then shortens that leg. Okay, and we need to use a traction splint to fix that. There are several different traction splints in the world, but all of them operate in the same way. They stabilize the femur using a solid pelvis, and we'll talk about that in class. But to know that if you're going to put a femur fracture, stabilize that with a traction splint, I can tell you this thing for sure. You have to make sure that their pelvis is stable, their knee is stable, their ankle is stable, their tib fib is stable. The only bone that can be broken here is the femur. If anything else is broken in that leg, you're just going to splint the leg with a board splint, and we'll worry about it from there. But if it's an isolated femur fracture, we can put the traction splint on. Here we see a guy that kind of buggered up his knee, right? And we're going to stabilize that position found. Now you notice he's kind of belted up there. There's some padding there to keep it in place. There are many different ways of doing this, as long as the knee doesn't move, the joint doesn't move, you are doing the right thing. Obviously, you're gonna pad it. You secure it in the best way possible. Slings, swath, cravats, whatever you want to use. Cling for that matter, whatever. But you don't want that to move, and you want to stabilize above and below the knee, and above and below in the joints above and below the injury site as well. Just like the arms, you can stabilize the legs. Like the lower leg, you can stabilize like a radial ulna. And we're just going to go ahead and put it in position found and stabilize it. Ankle and foot injuries, I love the pillow for this, or an air splint for this. You just kind of wrap the foot up in there and tie it into place. because in this position, there's really not much you can do for them other than to stabilize and to give them some oxygen and help transport. All right, so as you're practicing your splinting, make sure that we're doing it the same way every time. When you're doing this, one person stabilizes the injury and supports the injury, and the other person puts on the splint. This is a two-person event, right? You can't effectively do this with one person. Not stabilizing the C-spine and having them moving around a lot, that could cause paralysis or permanent vein damage. So we have to be very careful there, okay? We're not going to be moving that neck around. Hey, can you move your neck? No, I don't want to do that. If they're complaining of head, neck, and back pain, leave them alone. So again, here's the face. They got a little bit more in depth there, but you can see the suture lines on this patient here. It's housing the brain, right? And if I was to crush in any one of these bones, I'm probably going to have some fluid leaking. CSF is your fluid that is your cushion around your brain. So if I have bleeding from the nose or the ear, I want to make sure that I'm not losing brain fluid through an unseen fracture. So I'm going to take my 4x4 and I'm going to dip it into the blood that's coming out of the ear or the nose, and I'm going to see if there's haloing. There should be the blood part, and then if there's a clearer part that comes around it that looks like a halo around the blood, then I've got leaking of CSF, which is definitely a brain injury. This is not something to wait on. This is not we got to get them to the hospital right now for surgical intervention, brain shunts and everything else. Brain bleeds really bad. We have coup, contra coup. Coup meaning the first injury, contra coup being the second injury, right? So as it goes one way, I could have the brain, you see where they have the arrows on B, I have a direct brain hit, right? And then it causes the brain to swing forward and bruise on the other side. Coup, contra coup. Neck pains, we have brain swelling, we have open brain. If we see gray matter sticking out, it doesn't necessarily mean they're dead, but it does mean that they're in danger. Signs and symptoms of a skull or a brain injury, they're confused. Like, I don't know what's going on here. They're not acting right. You know who they are, and they're not acting like themselves. They're unconscious. They're nauseous. They're vomiting. They have blood from the ears. They're coming in and out of consciousness. They have unequal pupils. I mean, the list goes on. We all know these things, right? Here's a great picture of someone that had a closed head injury. Seriously bad injury. Now, she got popped. She got hit on her right eye, but her left eye bruised as well. And you can see here behind her ears, those are called battle signs. Bruising behind the ear. These things indicate severe head trauma, including skull fracture. If that's the case, she would not draw a nasopharyngeal airway. I'm afraid of pushing that NPA up into her brain. All right, what are we going to do to treat head and skull and brain injuries? Well, we're going to stabilize with a collar, right? And we want to make sure their airway is open. Remember, ABCs. Broken bones never killed anybody, but we don't want to try to paralyze them either, right? We want to make sure that they're breathing and they're getting good circulation to the brain. We don't want them to have hypoxia on top of everything else. Is there CSF seeping out of a wound from the nose or the ears? We've already talked about that. We need to control bleeding, but we're not going to, on the skull, we're not going to do super compressions. We're just going to basically be catching and doing a lightweight bleeding control, because we don't want sterile dressings, or we don't want to be putting additional pressure on the brain with those sterile dressings. And then we want to make sure that we're treating and looking for everything else that's going wrong with the body, okay? And make sure that the transport is getting ready for this patient. This is a serious patient. So when we're talking about facial injuries, how did they get this facial injury? Right? It's going to be depending on our treatment plan. As a result of the patient's face impacting a steering wheel or windshield, or is it a result of an assault? Was the assault with a fist or with a bat? Right? Or did they fall? Did they go face first into something and hurt themselves? Our primary objective in a facial injury is what is their airway doing? I need to make sure that their airway is patent. So if I take a facial injury, if they're conscious, I'm going to leave them sitting upright, and we're going to make sure that we're suctioning out blood and so forth. Otherwise, OPAs have to go in there. I can't put an NPA in because of those facial injuries. If they're unconscious, head in the neutral position and modified jaw thrust to keep it open. I might have to support them breathing. I definitely have to monitor circulation because with a head injury, it could cause altered breathing pattern. It could cause altered pulse rates. Now, again, because the cardiac muscle has its own way of running itself, the automaticity, it may cause a little bit of cardiac arrhythmia there. We need to make sure that we're controlling any bleeding. We don't want there to be just random blood, and death. We don't want that. We need to look for and stabilize any other serious injuries. But I'm not going to be messing around. Hey, look! If I press here on their skull, their leg twitches. We're not doing that. Okay. Again, with massive facial injuries, we're going to go ahead and put them on a backboard, and we're going to make sure that we're very cognizant of that C-spine. The mechanism of injury, we're very concerned about that. You can even have an internal decapitation where the head is pulled off of the vertebra and snaps the spinal column, and there's no visible signs from the outside. Anytime there's a hit to the spine or spinal cord, or any damage to the vertebrae, we stand a chance of having severe neurological issues. So we got to be very, very careful. Gentle movements, not a lot of movements, and things that can cause injuries to the spine are not necessarily just taking a shot to the head, right? It could be a gunshot wound to the chest. The mechanism throws them so much, right? Could be spinal cord injuries, specifically at that level, but there's a high mechanism there. Motor vehicle crashes, stabbings, other common MOIs, mechanism injuries that you may see out there depending on the area you work. Anytime there's a high energy transfer, always suspect there's a spinal injury. Again, do I see lacerations or bruises or any other signs that there's some internal damage, right? If they're complaining of pain, don't have them moving around. Are they weakness on one side? Definitely don't have them moving around, right? They can't feel or they have that tingling, burning sensation, like when your arm is just waking up from being asleep. That's a problem. If they've lost control of the bowel or the bladder, if they pee or poop themselves, chances are they've got a severe hit and possibly even a permanent damage to their nervous system, their spine. Neutral position, stabilize, keep the ABCs going, and arrange for immediate transport. Hook and book, shake and bake, you go with all that's all, right? We're looking for other things because they may not be able to tell you that there's other injuries. If they can't feel anything distantly to the injury site, they may not be able to know. If they don't know, they could be bleeding out and have no clue what's going on. Typically speaking, helmets don't need to be removed anymore. They have a way that you can just breathe around it. But if I have to, because of an airway problem, then I will stabilize above and below. I would stabilize front to back with the C-spine, gently remove the helmet, and then do normal C-spine and take C-spine precautions. However, it's a 6 in one hand, half a dozen in the other. How bad is it? We don't really know until we get in there, right? It's an if this, then that. If that, then this. Typically speaking, the only time that we remove all or part of the helmet is when I can't breathe for them, they can't breathe for themselves, or I can't immobilize the head properly. Now, when we talk about fractured ribs, one rib is bad enough. But if we have multiple ribs broken in multiple places, we call that a flail chest. And that's going to be where the chest is going to move in a paradoxical motion. Right here, you see just multiple ribs broken in one place. In that same thing, if I saw multiple breaks in those same ribs, then I have a destabilized part of the chest that I'm going to have to take care of. Any of these are going to be very difficult to breathe through. And on this one specifically, I might have some rupture to the lung, which is going to cause a bigger problem. You're going to see bruising, right? Shock is going to be a big thing here. I would stabilize this using a pillow or a blanket to stabilize, to pad that area. We really don't want them moving around a whole lot. They're probably not taking deep enough breaths, so we're going to want to make sure that they're getting some oxygen. So here's that flail chest I was talking about, right? 2 or more ribs broken in 2 or more places. They're saying 3 or more ribs broken in 2 or more places. Anytime that you have a chest moving in the wrong way, which is what's going to be here, I'm not going to get good movement here. I'm going to go ahead and make sure that they're not moving at all, if is humanly possible. I don't want them uh, to take huge breaths because it's going to cause additional damage. I'm going to pad that area just like I did for just the single broken ribs, and I'm maybe even tape some stuff into place to kind of hold it there. ABCs, high flow oxygen, immediate transport, because this is nothing to play around with. Because if I have multiple ribs broken in multiple places, I could even wind up with a pneumothorax, which is where I'm getting air in the chest wall. Or I might even have blood in there, which is a hemothorax. You see there on the right side of the patient, the left side of the screen, where the lung is not the same size as the other lung because of all that pressure that's in there, okay? And that is due to a penetrating chest wound, okay? So with the penetrating chest wounds, that might be a hole in the chest, gunshot, knife, whatever, and it might result in a sucking chest wound, right? You can hear it slurping in and out. And we want to cover that with an occlusive dressing immediately. But we're only going to tape it on 3 sides so it kind of burps. We're going to burp the chest like a Tupperware bowl. And we're going to make sure that if there's something still in there, we're going to leave it in there, right? Because if we pull it out, it'll make it worse, okay? All right, so that's the chapter 15. Let's do a couple of slides of review here. Now, remember, there's 3 different types of mechanisms of injury here. We have the direct force, we have the indirect force, and we have the twisting. So direct, I hit directly. The indirect force is an injury secondary to that first one, and a twisting force is where I'm rotating injury, right? In a way that is contrary to normal anatomy. I can have broken bones that are closed, where there's no skin that's broken open, or I have open, where the bone is sticking out. We have dislocations, which are tearing of the supporting ligaments of a joint. Lots of pain, and we go on from there. Sprains are excessive stretching of the supporting ligaments. Again, not necessarily dislocation, but definitely damage and pain. There are there's more than 3 types of splints, but basically speaking, in general, there's the rigid, like a board splint or something. There's a soft, a pillow, and then there's a traction splint that we'll use. The traction splint is only used for the femur. With the brain, or with the head, with the skull, we have a closed head injury, and when that brain swells, we might have there's going to be pressure on the brain, and it could cause irreversible brain damage. But we also might see some bleeding out of the ears and the nose with some CSF leaking out there. With those instances, we definitely want to get moving, okay? With head and neck and back and face injuries, airway obstruction is a primary danger, especially in the severe facial injuries. We want to definitely make sure that we have good airway control, maintenance, and high flow oxygen. And then finally, if you suspect a spinal injury, please do not move the patient during your exam. Make sure they get a collar on there, a longboard on there, and get them transported out. Lastly, chest injuries, we want to make sure that if they have rib fractures, which are just broken bones individually in the chest, or flail chest, which is multiple broken bones in multiple places, we want to be stabilizing that. Penetrating wounds could result in a sucking chest wound. If that be the case, we need to put an occlusive dressing on there. All right, chapter 15 for your enjoyment.